Hello, everyone. Welcome to PodBites, where we break down complex medical topics into bite sized pieces, perfect for your commute, coffee break, or whenever curiosity calls. I'm Aboussekhra, your host for today's episode, and today I'm joined by Aylin for a deep dive into some essential but often overlooked hematology topics.
Hi everyone, I'm Aylin, and today we're covering four major areas: the spleen, paraproteinaemia, multiple myeloma, PNH, and thrombotic microangiopathy. They might seem unrelated, but when you link them through blood cell destruction and immune regulation, everything starts making sense.
Now, first up is an organ that doesn't get nearly enough credit for how important it is: the spleen.
The spleen? It's important? Just kidding. The spleen has four major roles. It clears old red blood cells and circulating debris. It produces IgM antibodies. It acts as a backup hematopoietic organ. And lastly, it sequesters platelets and WBCs.
And that explains why splenomegaly can cause cytopenias. The enlarged spleen holds onto more cells than it should.
Exactly. And to make splenomegaly easier to remember, we usually group the causes into a few big categories. First, there are the congestive causes, anything that backs up blood flow, like portal hypertension or heart failure. Then we have the hematological causes, such as hemolytic anemias or thalassemia, where the spleen works overtime clearing abnormal cells. Next are the immunological causes, like rheumatoid arthritis and SLE. We also can't forget the infectious causes. We have malaria, leishmaniasis, TB, typhoid, and even EBV. Another important group is the lymphoproliferative disorders, including lymphomas, myeloma, and the myeloproliferative neoplasms. Then come the storage diseases like Gaucher and Niemann-Pick, where metabolic products start piling up in the spleen. And finally, there's a miscellaneous category, things like amyloidosis or metastatic cancer. So once you organize them into these categories, splenomegaly becomes way easier to approach and remember.
Got it. And here's a great clinical tip for examination that often shows up in practice. In portal hypertension, the spleen usually becomes palpable before the liver, because liver disease often shrinks the liver while congestive splenomegaly enlarges the spleen.
Absolutely. And recognizing that pattern can help you immediately suspect portal hypertension during an abdominal exam.
Now, once we identify splenomegaly, the next question is always, is the spleen overfunctioning or underfunctioning? And that's where hypersplenism and hyposplenism come in play. So basically, when splenomegaly causes cytopenias, we call it hypersplenism. The bone marrow stays normal or hypercellular, but the spleen traps the cells.
On the other hand, hyposplenism means reduced function, even with a present spleen. Think sickle cell disease, congenital asplenia, or splenic artery thrombosis. And in the case that you perform a blood smear, you will find whole jolly bodies, which are an indicative clue of hyposplenism. And speaking of spleen function, sometimes the issue isn't just that it's overactive or underactive. Sometimes the spleen itself becomes part of the problem and actually needs to be removed. But hey, do you know what removing the spleen is called?
Isn't that a splenectomy?
Correct, a splenectomy. So let's get into when it's actually indicated.
Let's do it. You'd consider a splenectomy for things like a splenic rupture, chronic ITP, hereditary spherocytosis, refractory AIHA, thalassemia, or even myelofibrosis.
And remember, after splenectomy, patients need vaccines for pneumococcus, meningococcus, and hemophilia influenza type B.
Exactly, but splenectomy isn't always the answer. In many cases, splenomegaly is just a reflection of an underlying disease, not something we fix surgically. Now, let's look at a classic example. A 42-year-old with chronic liver disease presents with abnormal fullness and thrombocytopenia. Imaging shows massive splenomegaly. What do you think is the case?
That's congestive splenomegaly from portal hypertension. In this case, you treat the underlying liver disease as splenectomy isn't the first-line option.
Great, now let's connect immune dysfunction to protein abnormalities, myeloma and paraproteinemia.
Sure. Paraproteinemia means a monoclonal immunoglobulin, or M protein, is present in the body. It occurs in myeloma, Waldenstrom, non-Hodgkin's lymphoma, chronic lymphocytic leukemia, and monoclonal gammopathy of undetermined significance, or MGUS.
And here's an important lab clue. A normal gamma region looks broad because of polyclonality, which just basically means it's made up of many different antibodies. But when you see a sharp, narrow spike, that points to a monoclonal process.
Exactly. And one of the most important causes of a monoclonal spike is multiple myeloma. Here's a case for you. A 67-year-old with worsening back pain and hypercalcemia has a monoclonal spike on SPEP. What do you think it is?
That's classic myeloma. Let's walk through what myeloma actually is and how it typically presents.
Myeloma is a malignant proliferation of plasma cells producing monoclonal proteins. Most patients are over 60, and prevalence is higher in individuals of African descent.
Exactly. And the clinical picture really reflects what these abnormal plasma cells are doing inside the body. Here are the three major symptom groups to look out for: bone lesions, so patients get bone pain or even fractures; low normal immunoglobulins, which makes them get infections more often; and renal failure, because light chains and high calcium can damage the kidneys.
And the way we formally assess these complications is through the CRAB criteria, which help determine if the monoclonal process is causing significant end organ damage.
So, what does CRAB stand for?
The C stands for increased calcium, the R is for renal failure, the A is for anemia, and finally, the B is for bone lesions.
Right, and once we see CRAB features suggesting end organ damage, the next step is confirming the diagnosis and assessing how advanced the disease is. That brings us to the myeloma workup and treatment approach. Can you tell us more about it?
Of course, workup includes bone marrow biopsy, SPEP, UPEP, immunofixation, IG quantification, skeletal survey, and finally, beta 2 microglobulin. Treatment varies based on fitness, transplant for younger patients, and melphalan-based regimens for older ones. Also, we have supportive care, which includes bisphosphonates, plasmapheresis for hyperviscosity, and IVIG for recurrent infections.
The next steps are to confirm it with a bone marrow biopsy and look for the CRAB criteria. Now that we've covered myeloma, let's shift gears to a completely different clonal stem cell disorder, one with a very unique mechanism: paroxysmal nocturnal hemoglobinuria, or PNH.
Sure, here is a case. A 32-year-old man reports dark urine every morning, fatigue, and occasional abdominal pain. He also notes shortness of breath and easy bruising. Labs show anemia with a high reticulocyte count, elevated LDH, low haptoglobin, indirect hyperbilirubinemia, and thrombocytopenia. His urine analysis reveals hemoglobinuria without red blood cells.
That's classic PNH.
PNH results from a PIGA mutation, causing loss of GPI-anchored proteins, which are CD55 and CD59, leaving cells unprotected from complement.
And without those surface proteins, red blood cells become extremely vulnerable to complement attack. That's why PNH causes episodic complement-mediated hemolysis, especially at night when complement activity naturally rises. And that mechanism explains the classic clinical picture we see in PNH.
Exactly. Let's talk about what it actually looks like in patients. PNH presents with hemolysis, bone marrow failure, and venous thrombosis.
And those clinical features show up on the peripheral smear as well, especially signs of active hemolysis.
That's about right. And once PNH is suspected, the diagnosis and management are very straightforward. Diagnosis is through flow cytometry for CD55 and CD59 deficiency. Furthermore, treatment includes eculizumab, anticoagulation, and transplant in severe cases.
Now, to build on the idea of hemolysis with cytopenias, let's connect this to another group of disorders where hemolysis is caused by mechanical destruction, the thrombotic microangiopathies, or TMAs. Let's look at a quick case.
A 38-year-old woman arrives with confusion, severe fatigue, and neupatchia over her legs. She mentions having mild fever and headache earlier in the day. Her labs show anemia, thrombocytopenia, and rising creatinine. A peripheral smear reveals numerous schistocytes, and her LDH is markedly elevated. She has no history of infection, diarrhea, or medication triggers. TMA is defined by microangiopathic hemolytic anemia, thrombocytopenia, and organ ischemia.
And the hallmark on smear is schistocytes, which must be more than 1% to diagnose microangiopathic hemolytic anemia.
Exactly. And TMAs come in different forms. So let's start with the primary ones. Primary TMAs include Shiga toxin-associated hemolytic uremic syndrome, complement-mediated thrombotic microangiopathy, and thrombotic thrombocytopenic purpura, also known as TTP. Then we have the secondary causes, which are triggered by things like severe hypertension, pregnancy, certain chemotherapy drugs, or transplant rejection.
Perfect. Now, among the primary TMAs, one of the most important and most time sensitive is TTP, which is a medical emergency. You have to start plasma exchange immediately, even before confirmatory testing. So let's break down what makes TTP unique.
TTP is due to Adam TS13 deficiency, leading to ultra-large von Willebrand factor multimers, and clinically, TTP is known for its classic pentad. We have fever, neurological symptoms, renal impairment, thrombocytopenia, and finally, microangiopathic hemolytic anemia.
Got it. Now, TTP isn't the only TMA you'll encounter. Another key one, especially in pediatrics, is hemolytic uremic syndrome, or HUS, and the Shiga toxin associated form typically happens after a child has bloody diarrhea.
And finally, beyond Shiga toxin, there's also complement-mediated TMA, which happens when the alternative pathway becomes overactive. This type responds well to eculizumab.
So, today we explored spleen function, splenomegaly, and hyposplenism. We also talked about paraproteinaemia and the CRAB criteria. We went over PNH and its triad, and finally, the TMA types, schistocytes, and emergencies.
4 very different topics, all unified by blood cell destruction and immune dysregulation.
And that wraps up today's episode. Thanks for tuning in to PodBites. We hope this episode helped make these hematology concepts a little clearer and easier to remember. If this episode helped, send it to a friend, preferably one who also panics at the sight of hematology flowcharts.
Stay curious, stay sharp, and we'll see you next time.